welcome everybody. So this meeting's been live streamed on YouTube, and it's also the first meeting we've had with the restrictions being lifted. So today's going to feel a bit weird for many people. If you're watching on the live stream or in the chamber, we're full of little screens, as well as some of us are still wearing masks. So for part of this meeting, we are going to try and do it in hybrid form. So we're going to be joined by a colleague from the CCG on Teams for the Healthy Western item. Now, we can see and hear you, Colin. I'm hoping you can do the same. You're nodding, so that's a positive. But for those of you on the live stream, we can't get the Teams audio to output to the live stream. So what we'll do is we'll edit those together at a later date. So my advice is if you're on the live stream watching Healthy Western, I would suggest you jump off and wait till we edit them together so you can hear it fully. So there are no virtual hands today, apart from yours, Colin. So if you want to speak, indicate to me and I'll call you. So one of the things I want to be clear is not all councillors are here today. Some have been unable to come, some have stayed home, just because we're trying to limit the spread as best we can. So just because somebody's not here, that doesn't mean they weren't interested, they just weren't able to make it today. So I'm going to get started, if that's okay. I should have probably introduced myself as a start. So I'm Councillor Kieran Connolly, I'm the chairman of the committee, and what I might do is I might ask people to introduce themselves if they can, because it's been a fair while, I think, since we've all seen each other, and this is what I look like in 3D. So I'm going to start on the left, because he's not watching, Andy Cole. Do you want to introduce yourself, Andy?
Yes, my name's Andy Cole, and I'm a councillor from Nelsey, Golden Valley.
And then I'm going to your left, so go on Hugh, and then we'll go round. Yeah, fair point, it's two Hughes. Hugh Gregor, do you want to introduce yourself? Okay, well, he's so, right, we'll come back to Hugh. Sandra.
Councillor Sandra Hearn, I'm from the Youngwood ward in Nailsea.
The other Hugh.
Hugh James, Portishead South.
And I'm going to go to the back bench.
Andrew Hollowood, I'm Deputy Medical Director of University Hospitals, Bristol and Weston.
Hello, hi, I'm Peter Brindle, I'm Medical Director.
Cool. Yeah, your microphone just occasionally drops itself off, so just be mindful of that one.
Hi, Claire Mackey, Head of Locality for Western Welland Villages for BNSSG CCG.
Colin, we're going to attempt to do yours.
Yes, good morning, everyone. Thank you very much for accommodating me. Colin Bradbury, Area Director for North Somerset for the Clinical Function Group.
Perfect, and we heard that really well as well. Hugh Gregor, do you want to introduce yourself? So that's Councillor Hugh Gregor. So we'll carry on. Right, so the first item on the agenda is election of the Vice Chairman. So I know we did this last time, but because of the new year, we need to do that again. So I know Councillor Cherry would still like to be Vice Chair. So if there's anybody else around here who would like to be Vice Chair, now is your moment before I put it to a vote. Nope, tumbleweed. So could I ask for somebody to propose, so Councillor Hugh James?
I'll propose.
And someone to second, Sandra Hearn. So all in favour? Cool, so that's covered. So Councillor Cherry is elected to Vice Chair. I'll let her know via text in a moment. Excellent, so public discussion. So we don't have anybody coming in to speak, so there's no one to cover that. Apologies for absence and notifications of substitutions. So I can run through these if you want. So we've got apologies from Councillor Ruth Jacobs, Councillor Ian Parker, Councillor Ros Willis, Georgie Bigg, Councillor Karen Havison, and Councillor Timothy Snaden, and Councillor Mike Bell isn't able to make it as well. Similar reasons, everyone's trying to reduce the spread. Any other apologies that I've missed? Nope. So with that then, we move on to item 4, which is declaration of disclosable pecuniary interest. Anybody got anything to say? Nope, we'll take that silence that there are no interests. So item 5 then is minutes. So these are the minutes from the meeting on the 18th of March. Any inaccuracies or things that need to be corrected in there that anybody's noticed? Nope. So could I have a proposer for those minutes then and a seconder? All in favour? Cool. If we go through it at this speed, we'll be done by 10:30. Excellent. Right. So matters referred by council. So there are none, but you'll remember there was a mental health champion that was proposed at council, and I'm touching on that at the work plan. So just to say that's covered elsewhere on the agenda. So item 7 is a Healthy Western review, but what I'm going to do is, just because I know a couple of colleagues have got to go, I'm going to bring forward the Central Western Primary Care Estate forward, just one item, just to allow that person to go before they need to. If that's okay with everybody, I know I've spoken to you privately, but publicly, if that's not keen, then let me know. So let me just move to my notes on this one, if that's okay. So you might remember this came about kind of at the last HOSP in March, where we were asked, so we set up a working group to kind of look at the accessibility concerns and things that were raised by the public. So we've done that. There's a report that's attached to the papers, which I'm not really going to run through, but part of the working group was myself, Councillor Willis, Councillor Jacobs and Councillor Hearn. So if I was to give you a summary, I suppose, of what's in the report, firstly, I want to thank the officers for supporting with this, and I mean those from the council and the CCG. You've been exceptionally supportive of this, and I know you've done a lot of work to answer our questions, so thank you for that, and I've got complete faith that you've kind of understood the challenges and they're proactively being addressed. An important thing to note, really, about accessibility in the health centre is that it's part of the wider development of Sunnyside Road, which the health centre is part of. So I just want to be clear so the context doesn't get lost, that it's not the CCG who's developing the land, it's Studio Hive. And the reason I raise that is sometimes I think publicly we think it's just entirely for the CCG to solve the accessibility issues, when actually it's a group of council, developers and the CCG. So I just wanted to be clear on that. And it's also important to note we're not at the stage where there's a planning application being submitted either. So this is really much about, we're at the early stages here, not the end of that. So the summary of what we found is it's entirely fair to say, as things stand, there are some accessibility issues on the site, particularly with serving it with public transport. And that's around the roads being too narrow and buses struggling to navigate the layout. So we looked at some mitigations, and we don't have all of those answers because we didn't get all of the responses from people we wrote to. But in general, we did identify that it is entirely feasible to serve the site with public transport, but that does require kind of everyone to work in partnerships to get that kind of revised and reconfigured, really. So we met the CCG last Friday, so that's the bit of the report that's missing. And they've been speaking with the developers and indeed the council, and it appears, and I'm happy to be corrected, that the developers have understood entirely the issue. But because we're at this early stage, we don't have anything concrete to say kind of what the solution will be. So what we're saying at the moment is, as things stand, if nothing changes, that access to public transport and access to public transport isn't incorporated into the site, we wouldn't be comfortable with supporting that. However, there is that caveat that I mentioned, that they are all speaking to each other. So if a proposal comes forward that kind of satisfies us that it solves, some of those concerns we have, then my suggestion would be we reconsider what I've just said there. And when I do the proposal later on, I'll add a little amendment to what I've written to say if something does change, that you guys can come back to the chairman, we'll reconvene that working group and we'll look at it again. But where things stand, if nothing changes, I think we would be really uncomfortable with supporting it. So that's kind of, I would say, the summary of that. And then before I go to councillors, I'm going to go to the CCG, if that's okay, for you to cover off your bit. Go on, Claire.
Yeah, thanks very much, Chair. So yes, just to note that we have indeed been working very closely with the developers to find a solution to accessibility to the site. However, obviously noting your point around sort of the accessibility and the wider point around the regeneration of the Station Gateway site, this will be something which we would look to have support from the partnership, from a partnership aspect on. Obviously, as part of the planning permission process, a transport feasibility study will have to be undertaken and submitted as part of that process. Studio Hive, the developer, have employed a transport consultant to do this feasibility element, and there are a number of options around the use of Sunnyside Road, adaptation to the site itself to enable a turning loop, and other options which are being considered at the moment, which will go into the planning application, which is due at the end of August. So they are at the moment waiting for a pre-application response, which will provide them with some feedback from the planning officers around their initial proposal. And then that will go into, obviously, the feedback to contribute towards their substantive response, which will go into the planning application. So I think to add to this, there are obviously some other options which have been looked into in terms of community voluntary transport, and further conversations are being had with Western Voluntary Transport Organisation to develop that further. So I think what I would support your comment, Kieran, Chair, sorry, in terms of coming back to the task and finish group once these proposals have gone through planning and looking at the proposal in the round for HOSP to then consider what the proposal looks like in full at that point.
Thank you, Claire. So I'm going to go to councillors. One of the things I should have said at the start of my introduction is, because I know some councillors couldn't make it, I told them if they've got questions, email them to me and I'll read them out, or if they've got a viewpoint. So I've got one of those, but I'll wait to see if anyone in the chamber's got any questions. Councillor Hugh James.
Just to check, since this report was written, have you had a response from First Group or ITU speaking for the Integrated Transport Unit speaking for First Group?
So I've had nothing back from First Bus, nothing in my pigeonhole. So the answer is it's no different from what I've written. That's actually also true for the Great Western that we wrote to. So neither have had a response from.
Bro, thanks.
Anybody else would like to say any comments or views on the report? Oh, sorry, go on, Colin. I saw that. So just for people at home, you won't be able to hear Colin, but as I said earlier, we'll edit Colin in. Go, Colin.
Thank you, and thanks for your clarificatory remarks there at the introduction of the report, Chair. And just to say, of course, to sort of put that in context, this is about the reciting of the Graham Road GP practice, which we know is not sustainable in long term due to limitations on the estate. We've gone through a long process of trying to find the best site within there, and the planning application, as you say, very correctly, is that it's still a work in progress. So very happy with the suggestion that we come back to the task and finish group once that work is complete. And just to sort of rehearse the fact that we would the rugby club development site, if I can call it that, would have been that site would have been less attractive, of course, if we thought that that was going to remain as it is. But we've got a very exciting set of proposals from the councils about houses, retail units, leisure facilities, and a school. So very keen to work with the council on the solution to those transport and public access links. And just to say that as things stand, we would not be satisfied either. So we're absolutely as one in terms of wanting to get the right solution, because I know public transport and accessibility is rightly a concern for many patients, and we will want to get that right in the work, and look forward to doing that in partnership with the developer and with the wider council for support.
Thank you. So I promised one of the councillors who was on that working group that I would say one of her comments, as I will do so. So Councillor Ruth Jacobs, who can't be here today, just wanted to be clear, when she was on that working group, that similar reasons again, she wouldn't be able to support it, and her concerns were particularly around the challenges that older, less mobile residents would have. Also, interestingly, she was down there for 30 minutes watching the people cross the road, so she's done her hard graft on that one. So what I'm going to suggest then, unless there's anybody else in the chamber, nothing in my recommendations has changes, aside from the fact that I'm going to propose a slight amendment to my own wording on bullet point 4, which says upon reconfiguration of the plans for the site, delete the rest of that sentence, and then just simply replace with the chairman will reconvene the working group to reconsider our position if there's new information. So that's the only change I was going to do. I'm imagining I'm going to need a proposer and a seconder for that. So Sandra, that's a proposal. Is anyone Andy seconding that? That's great. Apologies, Councillor Cole. Yeah, I need to get into the habit of calling people surnames rather than first names. So that will amend that proposal then. So the proposals are as in the report with addition to that amendment. Have I got a proposer and a seconder for that? Cool. So Councillor Sandra Hearn and Councillor Cole seconding. So thank you. So that one's passed. Excellent. So what we're going to do now, we'll move on to, back to where we were on the agenda, which is the Healthy Western Review. So this is going to be led by the area director. I think you're going to share your screen, is my assumption. But reminders to the public, you won't be able to hear the CCG, but we'll edit them together. So if you want to hear it, I suggest you jump off the live stream and come back at another time.
Thank you, Chair, and again, heartfelt thanks for the team to accommodate me in this sort of hybrid model, and apologies for those dialing into the live stream in advance. Just to clarify, the reason why I can't be with you physically today is not for want of trying. I have been told through the NHS app to self-isolate for 10 days, and today is the last of those 10 days. So unfortunately, I'm not a free man until 1 minute to midnight this evening, although I have had lateral flow and PCR tests are all negative. I'm following the guidance as recommended. So thank you again. In terms of the slide deck, what I might do actually is, rather than share my screen, is just take you through briefly the contents of the pack, which hopefully you've seen. In terms of the first few slides, just talk to them and then hand over to colleagues to take that forward. I can locate the PowerPoint pack if that's helpful, and we'll share latterly. But just to say, in terms of the pack, if you go to the second slide entitled Healthy Western within your slide deck, just to rehearse very quickly the context of this, following a sort of major public consultation exercise in 2019, we made decisions around changes to urgent and emergency care at Western Hospital, as well as emergency surgery, critical care and paediatrics. We said at the time that these changes were important and necessary. They were designed and supported by local doctors, and Doctors Hollywood and Brindle may want to sort of expand on that later, but they didn't go far enough. So they were necessary immediate changes, but we would have to return to that. However, in the meantime, just to go back for a moment, the Health Overview and Scrutiny Panel looked at these changes and wrote to us asking for a 1-year review covering the following 4 areas. And if you go to the slide marked background in your papers, that will give you the direct quote from the letter that we received about the 4 things that the Health Overview and Scrutiny Panel wanted to look at 1 year prior implementation. Now, it was agreed at the time that this was a little bit messy, because not all of the implementation timelines all started at the same time or finished at the same time, but we alighted upon a date, I think in April of this year, which has been postponed to this date due to the pandemic. So what I'm going to propose is that we go through those 4 in a little bit of detail within the pack. The first one about the staffing position for urgent emergency care and the prospect of sustainably returning to a 24/7 rota. I'll hand over to Andy Hollywood in a moment. The second one about recruiting primary care staff. I think UHBW and the CCG can cover together. The third one about the evaluation of the impact on the mental health community crisis and recovery centre, now called the Safe Haven Centre, the CCG can cover. And the fourth one about the number of people transferring to care elsewhere in the health system will be a UHBW-led presentation. And then I think we can come back to the next steps and conclusions if that's helpful. The final thing I'll just say on the next slide, which is entitled Context, just to say that there have been a few things that have happened since 2019, not least the first thing to say is in terms of planning, there's been a merger between University Hospitals Bristol and Western Area Health Trust to create University Hospitals Bristol and Western. That started on the 1st of April 2020, and again Andy Hollywood may want to say more about that. The second thing that's very much interlinked is, of course, the global pandemic, which has inevitably required changes to certain service models temporarily, and also has in some cases hampered understandably progress in things such as the integration of clinical services on the back of the merger, and also the progression of various elements of the changes that were agreed in 2019. The hospital and the wider health economy continues to have challenges around staffing and issues related to workforce more generally, and we sort of rehearse some of those issues within the papers. But we are now starting work again to develop a long-term future for the hospital and the wider health economy that serves Weston and Whirland villages. And I think we're very much keen to accentuate the positives and imagine a strong and exciting future for the hospital. Necessarily in these sorts of discussions, sometimes the focus on the challenges and the difficulties and the issues are understandable, but if we are to really sort of alight upon a sustainable model of care for the future, I think it's about selling a compelling and strong vision, because Weston General Hospital is a vital part of the healthcare infrastructure within Bristol, North Somerset and South Gloucestershire, and will continue to be so. So we're really clear that we want the hospital to be strong and successful. The question is, of course, what that strength and success best looks like. So what I will do now, if it's okay, is I will hand over to Andy to present the first slide on the staffing position, and I will now attempt to share my screen, if that's helpful.
Yeah, thank you.
Thank you, Colin. And yes, I'd like to reiterate that any future design of Weston has to be about that vibrant picture. What we're going to do now is just take you through the staffing position for urgent and emergency care. Colin, your slide isn't coming up, but hopefully everybody has it in their pack. As you're aware, we were looking and asked by council to consider whether we could go back, thank you, Colin, go back to a 24-hour-a-day, 7-day rota for ED. The staffing position in ED has remained very difficult. As you can see from the graphs on the left-hand side, the whole-time equivalents remain fairly static over the time periods described. But what we have been able to do is deploy and literally deploy. Paul Reevely is a military ED consultant, 2 tours in Afghanistan and a few others. And he's gone in as the clinical lead into Weston, providing clinical leadership, and has been able to develop one of our local clinical leaders to now become the clinical lead for ED in Weston. Strengthening that has also strengthened the support and education that the junior doctors have been receiving, and we have over the past year had 2 reports from Health Education England about the quality of training in ED, which is extremely encouraging. But as I say, the staffing position, though, still remains difficult, and we are reliant on temporary staffing to cover the gaps. Another positive, however, is we have just recruited a consultant to ED in both Weston and Bristol as a split site job, 50-50. As we see that those joint appointments of both organisations with an ability to rotate through them is what is going to drive the sustainability of that workforce, shared practice and development of quality. The nursing staff position remains as is. Again, it's been heavily reliant on bank and agency staff, and really follows that national picture that we're seeing in terms of the difficulty to recruit into certain lines as described there. But what we have been able to see is, I think, a stabilisation of that workforce. And as I say, through the improvements that we've seen in Health Education England quality reports, an improvement in terms of the training and education and the quality of care they're provided for patients attending the ED in that 14/7 period of time. What I think this also does describe is, while there has been no problems in terms of quality of care, it also suggests that I think there's no real position to take us back to a 24/7 rota, and we are still advising that we continue with that 14/7 rota system that we have and opening hours that we have for the ED department. Thank you. Thank you, Chair.
So what I might do is, I think if we take questions on kind of each one of those, you know, the 1, 2, 3 to 4s, we'll do it that way. So we're on number 1, the staffing position. Councillor Hugh James.
There we are. Thank you, Chair. So a question from Councillor Cherry and I, which is sort of about the international staffing problems. Are there any indications whether it's more COVID, whether it's Brexit and the migration problems in the UK at the moment, or whether it's Western General Hospital's reputation that are the biggest blots for recruitment? Because obviously one of those will eventually go away. The other one's public policy, and the other one, obviously, we are trying to work to basically how changeable is this recruitment problem, and also because we're doing this joint work with Bristol, what's Bristol's recruitment like at the moment? Are they themselves really struggling, or are we attached to a slightly healthier, broken hospital, or is Bristol in a much stronger state than us?
Thank you. It's difficult to unpick each of those three in the answer. We are across the country in a difficult position with regards to recruitment in all of those areas, and there are certain areas far more challenged than others. Respiratory physicians, for example, care of the elderly is another area. ED to a point as well, yes. We are following recruitment, both international, local. We're targeting individuals to bring them down. We're creating a far more vibrant environment to try and attract people, but we are still having difficulty, and that difficulty is across Bristol and Western as well. But we are in a better position now that we're able to offer these joint appointments, and I think once we find that people will start to come and work across the two, we'll find more people coming along with that. I can't actually unpick your answer completely, but we can find out a little bit more if you wanted.
No worries, thank you, that's really helpful.
Councillor Cole.
Yeah, are paying conditions an issue?
I'm not sure I can answer that. Paying conditions are fixed, clearly. We offer various incentives for areas that are difficult to recruit to. We offer opportunities to work across both sites, and in certain circumstances, there are appointments that are made where individuals have set times to do either research, education, quality improvements, managerial posts as well. So we're trying to both attract in terms of the individual's opportunities to develop them as individuals, both at a registrar and consultant level, as well as opportunities for recruitment retention incentives as well.
Any other questions before I ask some of my ones? Oh, cool. I'll ask some questions and jump in if you need. So, just kind of wanted to touch on a bit about the kind of the merger, if you will. So, you've mentioned some joint staffing arrangements for. There's one role in particular you're talking about. I was just thinking, are there plans for wider, I suppose, shared resourcing? I'm thinking of nursing, particularly, which seems to be a challenge according to the slides. It's almost like a commitment, isn't it, to a whole hospital approach rather than two separate sites as are seen as two separate hospitals. What are your thoughts and plans on those?
Yes, entirely. So, as we've described, the integration process to bring these two hospitals together is part and parcel of taking individual services, so ED becoming one ED department spread across two campus sites, single clinical lead, single processes, and an opportunity for individuals to move between the two areas in order to deliver the care. We have seen in certain areas, so while I think Colin has said the integration hasn't gone as quickly as one would want because of the pandemic and issues that we faced, we have seen significant successes in other areas. So ITU, for example, has 4 consultants who work across both sites at the moment in time to stabilise those services. We've seen pharmacy, sexual health, I'm just trying to think of the others, obs and gynae, the gynae services have come together over that period of time and are starting to drive that quality agenda. And so, yes, that is part and parcel of what we're doing, along with the joint appointments to bring together a sustainable service for Western.
Thank you. We'll touch on later on, because there's a proposal later on to work together to look at integration plans. The only other question I was going to mention here is a bit about the longer term ambitions. I know it's the next step, but I might ask it now. to you, Andy, what does that look like? You know, what is the feeling from your side of what a long-term vision for the hospital is?
It has to be as described. It has to be that vibrant, dynamic hospital that suits the population of Weston. It has to be part and parcel that is built together with primary, community, secondary care services to secure a sustainable position for Weston. That's what it has to be. What it ultimately looks like in 10 years' time, I think is difficult to say, but it has to focus around the population. It has to focus around the frail, the elderly. It has to have an acute service, and it has to deliver care for Weston. It has to be exciting. It has to be vibrant. We have to be able to encourage people, and I don't know whether anybody's seen that the various videos that we are doing with regards to the recruitment and retention for staff around nursing care. What is it that people are going to be attracted to come to Weston for? And that dynamic, that hospital that sits at the heart of a community, that sits close to where we are in such a, on a day like today, a lovely place to be, is what we should be attracting people for.
Yeah, absolutely. There aren't many places you can save lives by the sea. It's kind of how I would describe it. You can put that in a video. So I suppose the thing that worries me, and I know that worries the public and indeed councillors, is we'll be back here in 5 years' time talking about downgrading the hospital further. It's like, so what reassurances are there about, like, the only way for Weston now is up, in effect?
So we're not talking about downgrading anything. What we're talking about is making Weston an exciting place to come and work and live. It's about delivering care for patients in Weston and about delivering healthcare, and that's got to be an exciting model. What we can't have is a position where staffing is difficult, and as councillors described, reputation came out as that word that we have to avoid. The reputation for Weston has to be a place to come and be excited about living and working, and we have to change that. So, whatever we do, we have to move forward, and I think we've got to start and be responsible about where we talk. Because we should not be talking about downgrading a unit at all. We should be talking about an exciting new model.
I'd just like to add that I think the vision is that we will be seeing more and more patients at Weston over the years. So rather than downgrading in terms of less and less people going there, we're expecting it to be busier with more higher turnover, maybe a different mix of patients, but generally an increased number of people being served by Weston Hospital, far from any sign of downgrading.
Perfect, thank you. Any other councillors? So yeah, I agree. It needs a strong, big vision to get loads of people to. It's the place you want to work at, and that will help solve some of these challenges. So I'm going to suggest we move to slide 2, which is obviously progress in recruiting to primary care staff at the front door.
Thank you, Chair. I'll just move us along there. We've been trying to think laterally about how we might attract more capacity into the front door model of Weston Hospital, and one of the major initiatives that we've undertaken since 2019 is to introduce a service called Push Doctor, which is essentially a GP via video link, which is a thing that patients have become increasingly used to in day-to-day general practice as a result of the pandemic, although we were already looking for digital solutions for that sort of thing anyway. So this has helped actually accelerate some of this work. So there is now a facility, and has been for a number of months, for people coming to an A&E at Weston who are triaged to be suitable for an online GP consultation, to get that appointment the same day, and they can have that consultation in their own home, which I think is helpful in terms of allowing people with conditions of a similar nature in future to choose the best option for their care, which may well be primary care in a number of instances. There have, of course, been some bumps in the road in terms of implementation, again caused by the inevitable disruption of the pandemic, but we are seeing an increasing take up of that service. The other thing is the facility to use our wider health resources more effectively, with an opportunity for people to be diverted or redirected to Clevedon Minor Injury Unit when the hospital is busy and the MIU in Clevedon is less so, and that has been very well used by the local population, where they can see they can get the right treatment more quickly for certain minor injuries and ailments. And we're also looking, as Andy was saying earlier, to ensure that we have a much more integrated community and secondary care offer to support things like frailty, because our aspiration for Weston is for it to become a centre of excellence for frailty, and that plugs into the vision that Andy and others were describing a moment ago. So I'll stop there and ask if there's any of the colleagues who want to add anything to this slide before taking any comments or questions, if that's okay.
There's silence in the room from your colleagues, Colin, so I think we'll move to questions from councillors. Any questions at all from councillors? I have one from Councillor Parker who dropped me an email, so I'll do his then whilst anybody else. So obviously Councillor Parker can't be here, so he wanted to say he was interested to read about the GP with special interest in frailty, who was seconded for the 8 weeks. So he really applauds the initiative and having, as people probably know, some personal involvement with a local care home. He knows the attempts by good doctors would be very welcome. So he's got 3 questions on that, which is, how successful was it? If it was a success, is there any reason why it can't be continued? And then how were the care homes selected? Because he knows from a couple he's spoken to, they weren't aware about it.
I'm happy to start if I may. So I think it was successful. The issue about it being a long-term piece of work is of course that there would have to be backfill for the GP who's taken out of everyday general practice in order to be able to do that special piece of work. That was part of the pilot, and also a specific response to COVID. But we are looking to recruit additional GPs with a special interest to work in Weston, support our frailty offer, and particularly care home support. The care homes were chosen, I don't have the detailed hand, but broadly they were chosen in terms of in some parts scale, and also requests for help if there were particular concerns about how we can intervene upstream to enable people to be cared for within their own home, which is, after all, their care home, that's their place of residence, to avoid an admission to hospital via the A&E. So we do have plans afoot to strengthen that service and make it permanent. I'd be very pleased to bring a report back to the next meeting of this HOSP to give an update on progress in recruitment and development of the integrated frailty and care home model.
I think we'll take you up on that offer, if that's okay, at a future date. Any other councillors with questions on this slide? The only one from myself was around, it's actually similar to slide 1. We know recruiting say GPs is quite a struggle. I suppose it's the confidence around finding GPs to do that. How confident are you? Is this a tough gig like we were talking about the nurses? Are we in similar challenges here?
You want me to take that, Colin? I think it is. I think what this offers, though, is something slightly different in the ability to offer an appointment that works both in terms of A&E as well as only general practice. It gives you, it pulls from a bigger pool of people, so we can get people who are attracted to doing some hospital medicine while at the same time managing GP work, and that will attract more people to that area. That's what the hope is, and that's what should happen with these appointments. And it's a closer working relationship. The thing that we're trying to do here is break down these walls, break down the barriers, break down that front door, so it no longer looks like a primary secondary care interface. It's one. And if we can get people working both inside and outside, we'll get freer passage of patients through, and a greater ability to get patients back out, and the ability for them to be looked after in their local environment, in their homes, etc., through that support and that working practice.
Perfect, thank you. So in that case, there's no other questions. So if we move to point 3, which is evaluation of the mental health community crisis.
Yes, thank you. So Again, there was obviously a challenge in setting this service up in May of 2020 in the height of the first sort of spike of the pandemic. To start with, there was a decision taken following guidance and sort of advice from infection and prevention control experts to start this off as a telephone and video linked service for people in crisis. Within North Somerset and actually within the surrounding area, there was a supporter made available with any spare slots to the wider Bristol and South Gloucestershire population in that first stage. That service was well used under the circumstances, so I think we learned some valuable lessons. And of course, there's always been the aspiration for a blended model, so phone calls and video links were always part of the service model, but for the first part of the service's life, for understandable reasons, that was the only part in offer. However, we listened to service users who were very clear with us that although that was great, there was additional new capacity there to help people in crisis. And this is all about, of course, de-escalating. What was clear from the work we did in Healthy West is quite often when a person starts to struggle with their mental health, often the system pushes you up in terms of escalation rather than de-escalates you and supports you and holds you to enable you to sort of get back onto a more even keel. And that's what the Safe Haven Centre's all about, really. And users of the service said to us that they understood the risks and the challenges of running a service in the middle of a pandemic, but they felt that some face-to-face capacity was really important. It wasn't always appropriate to have only remote access. And so even though we were still in the full throes of the pandemic in February, we took the decision to offer a number of face-to-face appointment slots, of course, with all of the appropriate safeguards and checks in terms of infection prevention and control. And that's been also very well taken up. So from February, we've been essentially running the service that we originally envisaged in co-design with local people and service users. We've had a really encouraging rate of referral from a whole wide range of agencies, which I think indicates to us the need for this service, and the number of appointments and people accessing support continues to grow. Our next step, of course, is to start looking at longer term outcomes in relation to are we succeeding in helping people de-escalate and avoiding escalations to secondary care. The initial anecdotal evidence is very promising on that regard, but we obviously will have a proper evaluation once we've had the time for the longitudinal data to feed through. So again, if I may, I will pause there and ask if my colleagues had anything else to add, and then welcome any questions or comments.
So some head shaking here, so we'll go to questions from councillors. Councillor Cole.
Thank you, Chairman. The number of supported patients in North Somerset and South Gloucestershire, there's quite a contrast between the two figures, 179 in North Somerset and only 67 in South Gloss. Any particular reasons for those figures being so different?
Yes, I think so, in the sense that in the first stage, the initial response, as I mentioned, we offered additional overflow appointments, if you like, to South Gloucestershire, who also had some shortfall in capacity. So that was more about additional support to South Gloucestershire rather than it being specifically aimed at that area. So we've always been clear that Safe Haven is very much focused and grounded in a North Somerset footprint, but we were able to offer some mutual aid to South Gloucestershire where required for the additional appointments that you see in that first phase.
Councillor Hugh James.
Again, another question from myself and Councillor Cherry, really. She was, we were both really glad to hear about the successful redeployment of the Safe Haven team, but we were concerned with the NHS digital stats on young people with mental health problems, and was worried that they might be really missing from all this. So I know we're doing different work in our work plan on CAMS, but we were just concerned that young people might be missed during this crisis, because mental health wasn't exactly rosy pre-pandemic, and at the moment stats are particularly high. So just wanted some reassurances that that's also, they're also part of a crisis response at the moment.
Yes, thank you, and it's absolutely right that of course another very high priority is the service for children and adolescents in mental health crisis. So for reasons you'll understand, I know, it's important to have separate services for adults and have children's services which are different and need a specialist response. We have invested additional money over the past year in children and adolescent mental health, particularly a crisis service, and we're also setting up in North Somerset additional mental health support teams in schools, which will be phased in the next year to 2 years to provide additional support. So there is a lot of work going on that. It is a priority. It's not complete yet, that work, but I think we're making progress. That's not to say that, as I say, the job is done, but we are in parallel to the Safe Haven Centre, focusing very much on the services for children and young people with mental health issues.
Brilliant, thank you very much.
Just a question from me. So obviously it's kind of a story of two halves, isn't it? They've done incredibly well to operationalise. They've gone from telephone and then converted to face-to-face. So absolute credit to all staff in that. So what we know, I think, but a lot of research is telling us, is we're going to have an explosion of mental health difficulties and crises over the next couple of years because of the pandemic, and that worries me. So I suppose what role do we see Safe Haven Centre in that? Are we just, in the next years, we'll see an expansion of this? What are the thoughts there about how we deal with mental health crisis going forwards?
Thank you. There's a number of different aspects to our strategy on that, I think, and Peter may want to say more, but I'll start if I may, just to say that we are moving as part of sort of published legislative changes with the NHS to support the transformation into an integrated care system model from next year, from April next year onwards, subject to its progression through Parliament. That's a whole extra presentation on an integrated care system, but our first priority within the integrated care system model is to develop community mental health offers and develop them at a locality level. So that's at a sort of a place-based level, and as councillors I'm sure will be aware, we have two of these localities in North Somerset, one we call Western Moorland Villages and the other one Woodspring, and both of those localities led by local clinicians and operational council staff and the community voluntary sector are busy designing at the moment an integrated community mental health offer, which is supported by additional investment that ramps up over the next 3 years to ensure that I think in order, if we've got any chance of meeting the pent-up demand as forecast, we have to really get upstream, and I think that means trying to sort of head off where possible escalating problems at a community level. Often the first port of call is primary care as well as community voluntary sector, and ensuring that we've got the right services for those people, not only the clinical services but support around things like benefits and debt and family breakdown, all the sort of contributory factors that people will be well aware of. And as I say, that community mental health integrated care model, I think, is one of our major, one of the major planks of our response to try and address this potential significant increase in mental health demand. Although, of course, mental health demand is already very high, so we're not thinking that we've got everything on an even keel now. Regardless of any future additional demand, we think we need to redesign services to be much more integrated, very much in the same model Andy described for the hospital, where services are working in concert and are able to support the patient on their journey rather than being single separate episodes of care. I'll stop there and check if any colleagues want to come in on anything else, if that's okay.
Yep, Compere.
I just want to add that, of course, this is a national issue being recognised by our National Health.
Yeah, sorry, there you go, try again.
There we go. There we go. Got me now. So this is a national issue. It's been clearly picked up by our National Health Service in terms of investment in considerable increased investment in resources to pick this up. From a safe haven perspective, what we need to do and what we are going to be doing is being extremely responsive to any changes in demand as they appear. So we'll be clearly monitoring what's happening, and if there is the expected increase in demand, then we can bring that back and use some of the additional resources potentially that are available from national sources to boost that. But the key thing is loads of extra resources is being put in nationally for mental health in general, and from a safe haven point of view, we'll be monitoring it carefully and responding to the increased need when it appears.
But thank you, that's really reassuring to hear, because you hear all these stories about explosion of mental health, so as long as we're resourcing those appropriately, that's good. So I can see no other councillors. So in that case, we're going to move to point 4, which is around transferring to care elsewhere.
Thank you, Chair. Concerns initially when we proposed 14.7 ED were that patients would be transferring unnecessarily to Bristol and to surrounding hospitals. And one of the requests of Council was to assure ourselves of the number of patients transferring. These next 2 slides demonstrate the change over the past few years in terms of A&E attendances by the top right-hand slide, from people in Western postcode areas, and while you can see a slight increase in the numbers per month in 2019, 2021 has returned back to the 2017 levels. We've also seen, and one of the concerns clearly was that closure would mean that far more conveyances of ambulances to Bristol overnight, and that hasn't changed. We've not seen really an increase at all in the number of conveyances. And in fact, what we have seen are patients taking the opportunities to seek alternative healthcare provision in terms of 111 or talking to the GP or attending through daytime hours. We have been able to increase the number of patients admitted out of hours to Western General Hospital, which has offset this somewhat. And clearly this has to be taken into context with the reduction in ED admissions overall during pandemic, but is assuring in the sense that we are not overburdening the ambulance service overnight, nor are we unnecessarily transferring patients to Bristol overnight that should not be leaving our clearly Western catchment area. On slide 5, on the next slide, so this is looking at children. We're looking to increase the opening hours for the paediatric service into the early hours, because most of the time when children present, they present in the arms of their parents, and that often therefore means out of hours, working hours. They come in the evening, and so we're looking to extend those working hours for paediatric admissions. And overall, we have seen a reduction in the number of children attending ED in Bristol from Western. Although again, let's not herald this as the effect of this necessarily, but may well be an effect of the reduced number of admissions. But we are seeing it, and we haven't seen necessarily an increasing number of children having to move to Bristol either. We've been able to secure further paediatric nursing team in ED to support those children. And with the development of the consultants' increased hours as well, we'd hope to accelerate that further, so that, as I say, patients aren't having to be transferred to Bristol to be seen. If we move on to the next, this looks at patient safety concerns. Clearly, we need to be moving patients to the appropriate place for the delivery of care. That means some patients will always have to be transferred to an alternative area, an alternative hospital, because of the type of care that they require. We have a heart hospital, clearly. We have services where the patients need to be going in terms of acute stroke. One of this is looking at the friends and family patient safety incidents, and there's been no serious incidents noted during the closure of the ED. One of the issues that was borne out was that we were looking to transfer services, emergency theatre services, overnight. And that started around the January time as a preemptive way of looking and re-looking at every case that was transferred from Bristol, from Weston to Bristol overnight. We looked at serious harm, we looked at the transfer, we looked at all of that pathways. We looked at the number of minutes it took in order to get ED transfer and whether that actually contributed to the care of the patient. And I can assure you that there's been no change in the patient's care and no issues relating to quality or safety relating to those cases. And that is continually monitored, both in terms of the numbers and any concern or harm raised. The reason for doing that was, as we've previously described, in a year, there's generally only about 12 to 13 major laparotomy cases that occur in Weston overnight. So that's major abdominal surgery, compared to a significantly more number occurring in Bristol. With the number of patients, that require transfer, and the level of support that can be provided in terms of the overall care to a patient, it was felt it was more appropriate to transfer those patients overnight. And as of that date of February, when this slide was then looked at a month or two ago, there'd only been 5 patients in that total time, none of which had come to harm, all of which have actually had good quality care. And so again, I think that supports the decision that we had taken. Thank you. I'll stop there, Chair. Thank you very much.
Any questions from councillors? Nope. Just one more question from me. It was on point 4, which is to transfer to care elsewhere. Obviously, you can see from the slides, it goes up in 2019. It's about 7-ish% compared to 2018. So my question is, do we know what drove that? You know, was it the closure of Weston and people just dropping into Bristol? You know, was there a reason for that increase?
I would have to come back to you on that and look into that further. I wouldn't be surprised if it was that sudden closure that therefore people then reacclimatise to what they're required to do, and there's that need to transfer to, but I wouldn't. I'd be making assumptions there, and I would have to check for you, sir.
That's fine. I'd always rather an accurate answer than one that's on the spot, so that's fine. Any other councillors then before we move on to the next bit, which I think is summary and next steps, I think.
Thank you, Chair. I'll start if I may. I mean, this just rounds up, I think, what's already been said in terms of noting that the pandemic has been disruptive and presented huge challenges to the frontline staff working in Weston Hospital and within the surrounding services within the community. And I know that we're all very clear in our admiration for the work they've done under extremely challenging circumstances. I think the other thing, just to be very clear, to answer the question directly, we see no clear rationale to suggest returning to a 24/7 A&E staffing model in the future would improve patient outcome. Thirdly, progress has been made in bringing more primary care capacity into the front door, and we want to build on that work as outlined earlier in the presentation. The Safe Havens service has made a really good start, again under challenging circumstances, and is playing an important function within the system. And finally, the number of patients transferring to other hospitals as a result of Healthy Western changes is stable. And we have got good and recognised protocols. And just to, of course, point out that the temporary overnight closure that was initially instigated on the back of a CQC report happened in 2017, I believe. So of course, there's been some time now in order to make sure we've got those clinical pathways and protocols well rehearsed and well sort of well understood and followed by all clinicians in the ambulance service on a daily basis. So I will just, if I may, I'll just go to next steps, and that's the final slide, and then again ask if there's any other comments from other colleagues or any questions from the councillors. So the next steps is that we, see continue to support the management of the current staffing and operational pressures, of which there are a number in Western Hospital, not uniquely, but there are some specific challenges that we've outlined earlier in the presentation. There is an ongoing plan to recover services following COVID-19, particularly around elective care, planned operations, and there's work afoot with it across Bristol, North Somerset and South Gloucestershire to do that. As Ms Hollywood's already said, there's progress now to integrate the clinical services across UHBW, and finally, as again has already been mentioned, we're now in the process of developing a set of long-term proposals to ensure that Weston can be strong and focused and dynamic hospital in the community, and I think by the time of the next HOSP we will have a much clearer sense of the direction of travel, and will of course engage councillors and the public at every step of that process, and particularly if there are any further changes to service delivery that will be proposed. So thank you very much again for allowing us this time on the agenda. I'll stop there and ask if there's anything else that others want to bring in.
Go on, Peter.
Yeah, I just want to add that these changes, because we were uncertain about what they might look like, have been extremely carefully evaluated, and the data presented today in summary form, I think, gives us really strong assurance that it's had no significant impact on other parts of our healthcare system, and no clinical concerns have been raised at all, which is extremely reassuring. And I think now all efforts, all eyes are on the future to ensure that Weston has got a strong and stable future that serves not only the population of Weston extremely well, but is a vital part of our wider healthcare system across Bristol and South Gloucestershire too.
Thank you. Any councillors wish to add anything before I use my chair's privilege to do so? So just I suppose the first point, and I think that I'm speaking on behalf of Hosp here, that definitely getting involved in long-term proposals I think is really important for us. We need a hospital, as you say, that's vibrant, that's exciting, that has the staff that it needs and serves the population it needs. So we're up for that. Engage with us on that. Just on phase 2 of Healthy Weston, you're going to need to remind me, is that still got to be subject to public consultation? What's the situation there of phase 2 of Healthy Weston?
Well, that of course depends on what the second phase proposals say. So we did describe a potential long-term future for the hospital within the original consultation, but that wasn't formally consulted upon. So Andy is leading a group of senior clinicians at the moment to refresh and update those proposals in light of learning impact of COVID, and also the sort of benefit of having run the site now for over a year in terms of what might be best able to meet that population need. So of course, if there are any significant service change, it will follow the guidance in terms of consultation.
Thank you. Councillor Hugh Gregor.
Thank you very much, and thank you for all the hard work that's going on to produce these sort of results. My main point was we must remind ourselves that the recovery period from people who've caught COVID is going to be a burden for years and years and years, far longer than people realise, I think.
Did one of you want to pick that up? Peter?
Yeah, absolutely. And again, this is another thing that thankfully has been well recognised at a national level. Very considerable additional resources are being put into specifically designing and running long COVID services. So we recognise that this will be a problem. The scale of it does remain a little uncertain, to be honest, but we know that it's going to be there to some degree. And within our region, we have, in common with everywhere actually in the country, we have set up well-resourced and growing services to meet those needs, being referred directly in by general practitioners into that service.
Perfect, thank you. So I can see no other questions. I'm just going to close this item on the agenda by, so clearly a lot of work is being done, a lot of work still needs to be done, and a lot of it was derailed by COVID. I think that's a pretty fair summary. One of the things that we've discussed is the integration aspects of the merger, and that perhaps not being where it could be because, you know, COVID and all that. So for me, that's a critical part of some of this. So I'm going to propose, and the hospital are already aware of this, that we're going to set up a working group of councillors, and indeed if the CCG want to come in on that, you're more than welcome, to look at the integration plan and monitor that, because that really feels a key thing we need to get right. So I'm going to propose that, and we would appoint the councillors after this meeting. I'm not going to worry about that today, and the frequency we'll work out with the hospital. But I just want to check with councillors if they're content with that, because I'll need a proposer and a seconder for a working group to be set up to look at the integration plan of the hospitals, I should say. So I can see Hugh James as a proposal and seconders Sandra Hearn. Is there anything you want to add on to that, Andy?
No, thank you very much, Chair. No, we welcome that. I think it's a great opportunity to discuss and describe that ability to manage the organisation as one, and helps describe Western as we have. Thank you.
Excellent. So on that then, that's that agenda item done and closed. I'm mindful our public health director's only just come in, so I might give you a few moments by moving forward the work plan, if that's okay. So the item next on the agenda is the work plan. So I think I can summarise that by saying I've kept you all busy since I've been here in January. So we've touched on some of the projects we've got already. So the Central Western Primary Estate we touched on earlier. We're also doing a joint group with the Children's and Young Persons Scrutiny Panel around kind of children's mental health. So that work's still ongoing. We're currently at the stage of looking at gaps around funding, and we've had a deluge of quality accounts come in that we've been responding to. So we've done UHBW, Sirona, and AWP. On the work plan, you'll see there's some future projects we've noted, so around the ICS and around COVID recovery and dealing with backlogs, so picking up your point earlier, Councillor Gregor. But we will also be adding to that list eating disorders and accessing dentists at some point. So is there any future projects that aren't covered that councillors would like to see covered, or anything like that? Go on, Councillor Hugh James.
Just that a very long time ago, I think 2 chairs ago, we said that we might try and cover trans health inequalities. We weren't able to do that. By we, I mean I didn't have enough time, but I still just want to say I still want to try and focus on that sometime before the next 2 years are over, just because it is obviously still a huge inequality locally.
Yeah, I've actually thought about this one. I haven't chatted to you about it, but what we were thinking of is there aren't very many services in the Southwest. I think that's true. So we're thinking of if there's something we could do and then bring other councils in with us to do like a briefing or something together rather than to keep it to North Somerset. Because
that sounds very sensible. Yeah, that sounds like a good thing to do, a joint hosp.
Yeah, so we'll pick that up. I was going to chat with you through that. But yeah, that's not on the plan, but it's in my head. The other stuff just to be aware of is October's hosp is currently looking like we'll do something around winter pressures, long COVID, sexual health services. I know that's been on the list for a while. Cancer services, and there's a stroke program running probably with the joint hosp. So that's what it's looking like going forward. So any other comments on that? Nope. In that case, I've got the mental health champion. I can't forget that. So you might remember full council, there was a motion from Councillor Caritas Charles around a councillor being nominated for the mental health champion. So I asked 4 people to come forwards, and I've had 1 person come forwards, which is Councillor Mike Solomon. I've had a chat with him on the phone. He's all up for it. He understands the role. Our role on HOSP is just to actually recommend to group leaders to appoint somebody for that mental health champion. Unless there's anybody else in this room who wishes to put themselves forward for it, I'm going to propose we put forward Councillor Mike Solomon. If I can have a seconder.
Very happy to second that.
Okay, Councillor Hugh James. So a quick vote then. Are we all content with that? Show your hands. Cool, that's unanimous. So I'll do what I need to do to get it to where it needs to go, but Councillor Mike Solomon will be put forward for the mental health champion. So that's that done. So we're now going to do what now I think will be the final item of the agenda, which is around the health and wellbeing strategy. So I'm going to hand over to our Director of Public Health.
Thank you very much, Chair, and apologies everyone for being late. I was actually running a session with our own staff around health and wellbeing strategy, so it's a nice kind of theme of this morning. So despite COVID and all of the noise around COVID, we are trying to think long term about health and wellbeing. So I'm very pleased to be able to present to you now what is almost at the version of a published strategy, which will be published later this month. What I'm going to do is just run through a few slides to explain how we've got to this point. And what our intentions are going forward, if that's okay, and I'm very happy to take questions as we go along or at the end if that's useful. So very briefly, the strategy itself is a 3-year strategy. What we're trying to do is to create a space where we have a shared vision and some clear ambitions for improving health and wellbeing, and importantly reducing health inequalities as well as one of the Council's key ambitions and a stated ambition of our colleagues in the health service as well. We've got some key principles that underpin that approach, and we have some themes that enable us to take that forward in a structured way. We've also built this strategy to give some assurance to councillors that there's been a good analysis of health need in North Somerset, both health need and wellbeing potential, and also working with a number of different organisations to make sure that we've engaged widely to try and make sure that's reflective of the lived experience of people in North Somerset. We've also said something about a bit of the governance, of which this group will be a really important part in terms of making sure we're getting the right outcomes. And we're working through, we have an initial action plan within the strategy, but there will be more detailed work over the next 2 or 3 months to provide a much more detailed roadmap for the Health and Wellbeing Board as the overall sponsor of this particular strategy. So just going through, we've spoken to the Health and Wellbeing Board earlier this month. We're speaking to yourselves today. We've also done a round of final reflections within the authority and with some of our health colleagues as well at the Integrated Care Partnership meetings, but also with our, for example, our leadership development team this morning. We picked up another few comments and suggestions which were very helpful. So we'll publish by the end of this month, and that will be formally received by the Health and Wellbeing Board at its next meeting in October. And they will oversee the ongoing monitoring of how those outcomes are being delivered, and indeed that would be a sort of a keeping the score report that could be shared with this panel as well, so you can see how things are progressing. It's also fair to say that we're not trying to launch a strategy that sits on a shelf. We will be doing an annual refresh of the action plan to make sure that we're taking advantage of any new opportunities, but also being reflective of new and emerging issues that might be coming through in terms of population need. In terms of the sort of a schematic showing you in terms of the Health and Wellbeing Board, taking leadership around the strategy, but working very closely for us with both the broader council and this panel. We're linking into the health and care system around the integrated care system there with Healthier Together, and across the 3 health and wellbeing boards we're trying to do as much as we can in a collaborative way with our colleagues in Bristol and South Gloucestershire, because a lot of the system that they work in is very similar. We want to reflect local needs, but we want to do things together where we can. And then coming down from the North Somerset level, at the local level, we've already started work to integrate the action plan for the health and wellbeing strategy with the work programmes in the Integrated Care Partnership. So that sort of delivery mechanism where we've got lots of different providers working together. We've got voluntary community sector organisations in those integrated care partnerships. We've a lot of good collaboration. We'll make sure that the ambitions are played through in those plans as well, so that there's a good overall narrative for North Somerset. In terms of how we've built the strategy, so this is just a selection, but it's not everything that we looked at, but it's something giving you some assurance that we did a good analysis of health needs in terms of what were the key drivers for poor health or for premature mortality for people. And you can see on the left-hand side there for men and women, some of the key drivers are around things like circulatory disease, cancer, respiratory conditions, and indeed mental and behavioural issues, quite significant issue as well. The bit in the middle is burden of disease, so that's the global study which tries to pick out what the key conditions that drive premature morbidity, so people living with long-term conditions, which impacts the quality of their life, as well as then leading on to, unfortunately, premature death. And the picture on the right-hand side is just a quick illustration of the geographic variation within North Somerset, so the concentration of some inequalities in some of our communities. So all of that data is the underpinning story behind what's in the strategy, as is the conversations that we've had. Now, this was done during the time of the pandemic, so it possibly made it a less engaging process than we would have liked, but with the prospect of an annual refresh event, we can hopefully, by the time that comes around, be in a position where we can do more of that face-to-face conversation. But within this, we had surveys, we had meetings with different stakeholders, we had the comment at this panel back in February about looking for more engagement of young people, which we did. We worked with the college and we had some really good conversations with young people, picking up on some of their ambitions for better health and well-being. Different service users, the town and parish councils, and different sort of voluntary community sector forums as well, so that we were trying to get a good reflection on people's feelings about what was important and what we should concentrate on. Because the aim was to try and create a sort of a reasonable number of focused objectives that we could try and see some real progress on. So that's a bit of assurance around the process that we use. In terms of the priorities, and a lot of these, I suppose, are quite similar to things that have come up before, but possibly have even been amplified, particularly during the pandemic. So issues around mental health and well-being being seen as very important, including social isolation and loneliness. How do we keep people connected to other people as a fundamental building block of a happy and healthy life? Lots of ambition to see more change around physical activity, particularly everyday physical activity, things like active travel and everyday play for children. Issues around healthy diet, including food poverty, so not just about eating better, but actually making sure there's decent food for people to have in the first place, and enough to keep people healthy. And strong links as well around climate emergency, and lots of people thinking that could be a great mechanism, because some people may be less motivated by individual health issues, but they might be strongly motivated by wanting to do something to protect the environment, for example, around physical activity or changes in food patterns, for example, eating more fruit and veg as opposed to meat. So, and alongside that, in terms of the setting for all of the potential to improve outcomes in those areas around transport, housing, and the key issues around financial stability and employment. So, you know, what is the foundation on which people might have a reasonable chance of improving their health and well-being and maintaining good patterns throughout life? All of that has fed into a few key points around people were very sort of ambitious about our ability to try and do more around prevention and early intervention. Something about being really sensitive to community-based approaches, so understanding the needs within individual communities and allowing flexibility for those opportunities to be developed by the community, because much more likely they'll be sustainable that way. And also something about our accessibility of services, so making sure things are in the right place at the right time, in the right method, if you like, for it to be a fair ask of people to possibly then think about how they could do more to keep themselves healthy and well, or address an issue at an early stage. So some of those things are around thinking about service availability, thinking about that social model of change, so not seeing this as a medical issue, but how do we work with our colleagues, our friends, our community to become healthier and happier in that process. Very much around strengths-based, and I suppose the experience of the pandemic and the amazing response we've had from the voluntary community sector, it shows the huge potential there is to continue to use that for good health and well-being activities, which I know those organisations are very committed to. Strong focus on outdoor spaces, and not just as a COVID protection measure, but actually as a natural way in which we enhance our well-being. Lots of people connected with nature more, potentially in the pandemic, particularly in the first wave, where it was more in the summertime as opposed to the winter one. But people like that idea of being outside more. Lots around settings, so we've got good links already around our children's centres and early years providers. Can we do more with schools? And the answer is yes, and we're going to look to try and develop that. We're also looking to develop a workplace health programme through the action plan as well. So how can we reach out more into that world to keep people happy and healthy in the working age part of their life, Obviously about trying to provide people with the right information so they've got good knowledge and understanding, and every contact counts. So every health professional, actually every council officer who is in different situations in our social care teams, even our street wardens, whoever they might be, they will notice things, and if we give them the right skills and the right opportunities, then that could be a health enhancing interaction with somebody. So briefly, in terms of the vision, it's about trying to empower people to optimize their health and well-being, and it is that emphasis on a long and a happy, productive life. So it's thinking about the quality of life, not just measuring it in terms of numbers of years lived, although that is an important measure in its own right, and setting it very much in thriving communities, and doing that in a way that reduces the inequalities in health, so that we do more in those areas that might need extra support. And that creates our three themes around prevention, early intervention, and thriving communities. In terms of seeing that in one place, this might work for you, it might not, but it's kind of showing that we've got the three themes down the side there of prevention, early intervention, and thriving communities. And across the top, what we have is our 3 stages of life. So it's thinking about every opportunity throughout life. And we've structured the action plan so that we can think about, if you like, children and young people, working age adults, and then older adults, and what are the different types of interventions you might want to offer in those 3 life stages. Underneath that, these are the priority areas that came through in terms of mental health, physical activity, food. There's something about, I suppose, harmful substances in terms of tobacco, alcohol, and substance misuse as a particular risk to health, which came through quite strongly as well. And then working, and this is where the local authority particularly has a huge range of influence around employment skills, housing, transport, green infrastructure. So how do we create the right environment for people to feel like they can engage with some of these opportunities? In terms of some principles there, so they kind of what I've spoken about already, but we want to work in partnership with others. This is about an open opportunity for people to come into rather than seeing it as a closed shop. It's about the focus on tackling inequalities. It's also about this place-based approach, so back to that being sensitive to each community and where the opportunities are to make a difference.
Is it all right if I just challenge, sorry, do you just explain what the partnership acronyms are?
Oh yes, sorry, we've gone into tech speak there, I do apologise. So the integrated care system is the ICS, the integrated care partnerships are the ICPs, voluntary community, hang on, let me get this right. I'm tripping over that one. Voluntary community, social, faith, and I can't remember what the E stands for. Have you got it? Education. I think it might be education. So it's that broader community engagement. So apologies on that for going straight into speak that I couldn't even translate for myself. So there's a learning point for me. Thank you. So yeah, just go back to the inequalities bit. So that's about thinking the different ways we can do that. We can do that at a civic level in terms of, particularly at the council, in terms of policy and approach. We have the essential bit of community interaction and where things actually land and people make sense of them. And then we have a whole range of services, whether they're council either provided or commissioned services or NHS services or other interventions, where we want to try and coordinate those so they make sense for people. I've spoken about the life course perspective. We certainly want to always be thinking about looking at the data, looking at the insights of what matters to people, and the learning we've had through the COVID response, which I think we've built into some of the ways of working in the strategy and the action plan. And then very importantly, the council has an empowering community strategy. We want to work in that spirit of working with communities and building on the excellent work that's been done in the hugely challenging time that has been the pandemic. So what that translates into is, in terms of the action plan, what we'll have is the themes there: prevention, early intervention, and thriving communities. We've then got the health and wellbeing themes. So, for example, things like physical activity or food. We'll then have a focus on what stage in the life course we're looking at, and then we'll break that down into the individual objectives of the actions and the resources we're going to put behind it. So we are investing new money from the public health budget to try and push forward on the action plan. We're also connecting in with others. So, for example, one of our action areas is around extending our health trainer service, and we're collaborating with our colleagues in Peer Health to be able to do that. They have some funding opportunities. So rather than do something separate, we're trying to integrate and have one service that could serve the needs of some of our more vulnerable people, particularly in Weston-super-Mare and the surrounding area. So that's an example. So we'll work our way through all of that in terms of the detailed action plan. And I suppose then it's just really to get some feedback from the panel now, if that's okay, around the approach we've taken, whether you feel comfortable with that, whether there's anything more you'd like to know more about or more emphasis we could put, and then we can feed that into the development of that action plan, and then obviously that will be fed back to you so you can reflect on that, and the ongoing monitoring will be an important part of the process. Is that okay?
Yep. Thanks, Matt. So I've caught Councillor Hearn's hand. Anybody else? And then Councillor Hugh James. So Councillor Hearn.
Thank you, Chair. It was a statistic that was up on one of the early charts where you had different things to do with split male and female. And I noticed male deaths under 28 days at 3.3%, but I didn't see anything for females. Now, when my children were small, we heard an awful lot of stuff to do with cot death and what have you. I'm the only female in this room, and there's an awful lot of males, so I'm just wondering sort of what the disparity is and what's the cause.
Is that helpful? So, sorry, I can't even see with the glasses. Yeah, so in terms of infant mortality, it is quite low anyway. There will be a range of factors in there, and it gets just above the line. So the female will be in there as well, but I'll have to take that away and get the more detailed analysis for you, and I can send it through to you. But I suppose in terms of the context of this strategy, it's probably a bit of a distractor because it's a very specific kind of medical issue if it's at such a young age, but it's just because it's reached a certain threshold in terms of the percentage that it's featured on the chart there. But I'll need to look at the background data, but if I send you an update on that, would that be okay? Or I can send it around to the whole panel if that's useful. People are interested in that data.
Yeah, if you send it to me, I'll circulate that around. Thank you.
Thank you.
Councillor Hugh James.
Yeah, so a couple of questions, if that's all right. It was useful going through this and refreshing myself with the public health indicators of the area, because obviously that's what this is all about, trying to make the most meaningful impact. I noticed when doing that between 2010 and 2015, for the lowest, the most deprived areas, health has really shot up in that time, and since 2015 and 2019, it's sort of stagnated or even decreased. Is there a difference in the approach in the area, or do you know the most significant thing that sort of stops that improvement in health locally? And, you know, is it to do with the way that services have been done, or is it more to do with the lives of people? Is it, you know, a people problem, or is it us, how we've been doing our services problem? And yeah, just for you, what's going to be different about this strategy from how we're doing things? For you've really explained it, which is more community-based, more holistic, more partnerships, more money. But like, is there, I mean, I suppose that's it, but is there anything significantly different in the way that's going to change things, do you think? I think that's okay for one question to start off with.
Fine. So in terms of the fall in the indicators or the stagnation, that's actually a national issue as well. So I guess that would point towards probably more impacts of potentially some of the austerity budget cuts and the cumulative impact in that in terms of a slowing of the improvement. So the life expectancy tipping just over the edge now. So instead of that continual increase and healthy life expectancy, you're seeing that across the country, that it's either stagnated or started to tip down. So I suspect it's very hard to put that down to one individual factor, but I think that's a very strong common issue across the country. And we would expect to see a disproportionate impact probably on some of those. So if you start in a more vulnerable position and you have that additional impact on you, then it's more likely that you'll struggle even more. I suppose you get the compounding effect of already being in a difficult place. And then if you have less access to support and advice, then that can have a larger impact on you as opposed to a community which has more natural resources, whether that's people with more money naturally because they've got higher paid work, or you know, a school that's better performing, or, you know, all of those sorts of things. So I suppose in this strategy, what we're trying to do is to say we want to have an impact across the whole of North Somerset, but we are going to target additional support in those areas which have probably suffered most in terms of negative impacts over the last few years, in terms of life expectancy, healthy life expectancy, and just prospects for children and young people coming through, people getting good employment, all of those factors that then drive that cycle. Unfortunately, it's really quite hard to get out of sometimes.
Thank you, that's really helpful. The other thing, working with place-based groups like, I know anchor organisations like, obviously I work strongly with Alliance, really good, I'm really glad you're doing that. Something to do with what Sandra said actually, I understand why it's not here because it's not a priority for people and it doesn't lead to deaths other than, as Sandra's pointed out, stillborn deaths. But sexual health, I thought I'd just give that mention because testing levels are really low for the region here in North Somerset. Actual levels aren't that low, like chlamydia levels are now much lower here than they used to be, but testing levels are still pretty appalling around here. So is that going to be part of this plan, or is it just that that appears on a different sort of strategy to this? Because there's no mention of that within the strategy, or is that just because there's only so many words on a piece of paper?
So in terms of sexual health, it probably won't be delivered so much through this strategy, but is another area on our radar in terms of things that need to be looked at. And I suppose one of the challenges we have as well at the moment, not just, so it's access to testing. One of the budgets which has been impacted by the reduction in grant to local authorities has been sexual health services as one of our main commission services. It's also impacted on our substance misuse and our children's budgets as well as our three main commission services. So we will be looking at that again, and particularly because of the disruptive impact of COVID, some of the services we would have liked more of to be available in the community, particularly around GP surgeries and pharmacies, have also been interrupted by people's access to services. Some have stayed relatively high, so things like long-acting reversible contraception has stayed, but wider sexual health work in terms of testing and preventative messages and all of those sorts of things are less effective now. So I suppose what I'd say is it's probably not so much in this strategy, but we are looking at that at the moment alongside our colleagues in Bristol and South Gloucestershire, because we've commissioned a lot of those services together. But there needs to be a rethink in terms of how we can do better in that space too, because I agree with you. It's a worrying area because it can have long-term health impacts if it's not addressed properly.
Brilliant, and we'll look at that more in October, I suppose. The final thing, if it's all right, is just where will make the most meaningful difference? Because I've looked at the area indicators, and for example, here tobacco use is the lowest it is in, if not the country, at least the southwest. So we know that putting more money in that might not be the most effective thing for improving health outcomes. Do you know where you get the most bang for your buck in terms of putting more concentration?
Yeah, so you can look at it different ways, and I suppose it depends on which group you're looking at in any one circumstance, but tobacco is still really important. So if you can get someone to stop smoking, huge impact on their health and well-being. You can also think about, particularly if that's an adult with children, the impact on the health and well-being of the wider family as well, so you get a collective huge impact. I think the other area which is strong in this strategy as well, so that's in there, it's not one of the headline figures, but it's something we'll continue to work on. One of the other areas which is in there is physical activity and food. So actually, in terms of the impact of obesity as a pandemic, all of its own, if you like, in terms of impact on our population, the more that we can do. We have had some additional grant this year from central government around weight management work, but I think what we're trying to do through this strategy is much more in the prevention, early intervention space. So, for example, children in school, if we can get them moving regularly at school, and schools are very committed to this, but if there's more that we can do, both getting them to and from school in an active way, more around that, and you normalise physical activity as part of everyday life, like, for example, I don't know, if you go to Holland, the amount of bicycle usage, but of course they have an excellent infrastructure there which enables that, and culturally then it takes hold a bit more. So there are some things that are long term where you try and build a culture of doing things, but there are short-term things as well if you can just get people out more. And I think over the pandemic, the amount of people who've connected with nature more is, if we can use that as a dynamic to build on, and get more people physically active, because it is such a huge impact in terms of reducing your risk of cardiovascular disease, cancer, stroke. All of these things are often related to sedentary lifestyles and unhealthy diets, plus with tobacco and alcohol as additional risk factors. And of course, we also then invest in people's mental health, which is a fundamental building block for anyone being able to embrace a healthier and sustain a healthier lifestyle. And hopefully, if we go through the community angles, we'll have more realistic ways which we're understanding people's needs and what works for them. So one person's bike ride will be another person's trip to the allotment, or a walk in the park with a friend. And it's having that sensitivity to be able to adapt your approach, but get people moving more and reducing their risk significantly and improving their mental well-being as well.
Brilliant, thank you very much. I've recently taken up jogging and unfortunately found out that it does improve my mental health, so now I need to continue. Terrible.
So Councillor Hugh Gregor, and then it was Councillor Andy Cole after.
Oops. Thank you very much. You had a diagram earlier on, and right at the bottom of the screen, you showed how you divided up North Somerset into 3 areas: the north, the west, the south, and I wondered what had happened to the east.
Okay, I'm just going to have a look and see if I can find that.
I think I got that right.
So I'm not aware of a particular division. So was it the map?
No, not that.
Not that one. Was it? I think so. Do you want me to go back? Maybe it's that.
Much nearer the beginning. No. It was a.
Unless it was. So we started there. I'll just quickly run through them.
It was only on the screen for 2 seconds.
Okay. Just having a look to see if I can find it. So I think the only visual, we had that one there. But certainly in terms of dividing North Somerset up, most of what I've talked about is on the basis of North Somerset.
Well, it's just that it would be seemingly fairer if there was an area designated east in your thoughts. That's 6 village communities, and if you're not careful, they get swept under the carpet and forgotten about.
No, really important, and I think that's where, within the strategy, working with the Empowering Communities strategy, which is North Somerset wide, so that is going down to the individual kind of town and parish council level, of how we work with those infrastructures to be able to pick out those opportunities to deliver on some of the aspects of this plan. So yeah, just to assure you, it very much is part of the plan to make sure that every bit of North Somerset has a
There's another slight problem too, is the main surgery isn't even in North Somerset. We're so far to the east.
Yes, and I recognise that. A lot of these interventions will not be GP based. So most of the services that are commissioned through GPs is at a slightly different level in terms of higher up the level of individual needs. So most of these will be community based. So therefore, hopefully that will
I'll look forward to all your work.
serve your constituents well.
I couldn't actually find the slide. Apologies to you that you were referring to. Councillor Andy Cole.
Thank you. You mentioned several times the importance of early intervention regarding young people and children. Does that include regular engagement with primary schools?
Yes, it does. So it will be through the Healthy Schools programme, which we have already, but we're looking to try and extend that. So that's working both within the public health team, but with colleagues in the children's directorate here, and also our school nursing service. So we're looking at how we can build up more activity through primary schools and secondary schools to maximise the opportunity for those teachers and those communities to be able to use the resources that we're going to be developing as part of the strategy. So yeah, very much with primary, and indeed preschool as well. There's quite a lot of work in the early years sector as well, both through children's centres and providers.
So do you contact all the schools on an even basis?
Yes, yeah. So the Healthy Schools programme is offered to all primary schools in North Somerset and all secondaries as well. And some will already be doing certain things, which, you know, absolutely fine. They work in certain ways, and particularly across the academies, they might have certain ways of working between the different schools. But we certainly get alongside them and try and make sure they've got all the right resources and opportunities to take part.
Thank you.
Thanks.
Any other questions or comments from councillors? I'll just finish by saying I suppose when I was reading through this, one of the stark stats that came out to me as to why this is so important was the one about life expectancy. So if you're male, you will die 10 years earlier in the most deprived area you will in the least, and that shows the real importance of this. And I think my personal view is you've got the priorities right. I think my only question is this, as you say, involves everybody. Particularly other organisations. So how confident are we that other organisations will put their resources to it and their commitments?
Yeah, so I suppose one of our key relationships will be with colleagues in the health sector. And so, in fact, I've got a meeting later today talking through with the integrated care partnerships about how we align resources. And there will be hopefully some more opportunities to bring new resources in. So we're committing budget from the public health team. And as new NHS money comes through, particularly there's a greater emphasis on inequalities now. So there may be opportunities to say, well, this is the plan for North Somerset. As new opportunities come up, we'd like you to come alongside us and help us either deliver new things or deliver the programme at greater scale so we can reach more people. And that's the type of conversation we've had within those areas, and people are keen to work in that way so that there's not confusion. There's one kind of story and emphasis on what we need to do to try and improve life expectancy, and indeed healthy life expectancy, because it's not just dying 10 years younger, it could be 16 or 17 years earlier that you go into poor health. So that's a huge impact on people's lives. And, you know, everything we can do together to reverse that type of dynamic not only improves the outcomes for those individuals, but it actually helps our organisations because it will reduce pressure on the services, the types of acute services that are obviously under extreme pressure at the moment. So hopefully it's in everyone's interest, both kind of morally and kind of service-wise. It makes sense to go to as much prevention and early intervention as we can.
Perfect, thank you. So obviously you don't need endorsement or approval because obviously it's health and wellbeing board that this goes to, but I kind of would like to show hospice an endorsement if that's okay. So my recommendation would be that hospice entirely supports your strategy, and I'll be looking for a proposer in a second. Well, I'm proposing, aren't I? So I'm looking for a seconder, which counts a huge aim. So is everyone in favour that, you know, we think broadly that this strategy is right? Show me your hands. Cool. That's everybody, so it's unanimous. So thank you for that, Matt.
Thank you, Chair.
So that, unless I've missed an item of the agenda, does bring us to the end of this meeting. So firstly, thank you all for contributing today. For those of you watching on the live stream, apologies for the tech gremlins, but we will try, and I'll give you a politician's promise, which means you can't rely on it. We will try and put these together, the teams we had here and the live stream. If we can't, apologies in advance. I am a politician after all, so you can't always trust what I say. So with that then, there will be minutes out at next time, so you can pick those up if we're not able to merge the two things together. So thank you all. We'll see you next time. I think we can probably close the live stream now.